Thank you. I'm not used to getting applause for just walking up here. That's cool. So I have more disclosures this time than last time. So I'm not speaking on behalf of the Surviving Sepsis Campaign, but I'm part of the steering committee of the Surviving Sepsis Campaign. I'm going to talk a little bit about the new Sepsis 3 definitions that came out in JAMA earlier on this year. I'm an author on them. The Surviving Sepsis Campaign has new guidelines coming out in a couple of months. I'll be an author on those as well. And the other disclosures are the same as from previous. So I hope everybody in the room knows this, but I'm going to say this anyway. Between 230,000 and 370,000 people die of sepsis each year in the United States, making it the most common cause of death, third most common cause of death in the United States. If you look at national vital statistics, it will tell you that septicemia, which is a term that we do not think has existed since 1991, is the 11th most common cause of death. And it will tell you that pneumonia is the 5th most common cause of death. And as per my previous talk, people of pneumonia are actually dying of sepsis because whatever you have for your sepsis definition, it actually falls within sepsis. So the truth is, sepsis is a public health emergency. It's the 3rd most common cause of death. If you ask anybody what a heart attack is, they will know. If you ask anybody what cancer is, they will know. If you ask anybody what sepsis is, there's a very, very significant chance they will have no idea what it is. And it is important, and so I'm going to talk about it. There are 2 sepsis definitions out there right now, and it is a confusing time in the field and a wonderful time in the field. And I'm happy to take questions later about the pluses and minuses of sepsis 1 and sepsis 3. Sepsis 1 is the definition we have used for the last 25 years, and that is SIRS plus suspicion of infection, SIRS being temperature, heart rate, respiratory rate, white blood cell count. And if you add that and you add an organ dysfunction, you have severe sepsis. And if you add that and an inability to maintain your blood pressure, you have septic shock. And that was the definition we used until 2015. And then this year, Sepsis 3 came out, which is there's an actual definition and a clinical correlate at the bedside. The actual definition is an intellectual construct, which is sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. The understanding here behind here is if you look at a heart attack, the definition of a heart attack is not an elevated troponin. There's an actual intellectual of what a heart attack is, and you see at the bedside an elevated troponin. This is the same concept for sepsis. This is the intellectual construct, of course, and there's the same thing for an intellectual construct for septic shock, which is a subset in which underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. So that's great. It's an intellectual advance. It doesn't help us in the slightest at the bedside. So how do we actually operationalize this at the bedside? So at the bedside, organ dysfunction, which is what we're looking for in the setting of suspected infection, is a change of SOFA score of 2 or more from baseline. And why? Because if you have that, it gives you a 10% mortality. Septic shock at the bedside in the new definition is 2 things in terms of the clinical criteria. 1 is pressures, 2 is a lactic greater than 2, and you need them both. And the reason behind them is it gives you a mortality of 42% as opposed to either or, which is significantly lower. So again, I'm happy to take questions about Sepsis 1 and Sepsis 3 and the definitions. In and of itself, that's an hour-long talk, and I have been giving pro-cons around the world on that. I'm going to talk the rest of the time about sepsis management. There's going to be no basic science in this talk. So sepsis, it is hands down the best of times, and it is the worst of times. So why is it the best of times? Because we understand more about the nature of sepsis than ever before, and there's more and more studies coming out on sepsis than ever before in the highest caliber journals. 10 years ago, if you looked at the New England Journal of Medicine, maybe sepsis showed up once a year, and now it's showing up every 3rd issue, and there's a whole section in JAMA caring for the critically ill, and so that's wonderful, and we understand more about it than ever before, and that's awesome. And what's the downside is, while more and more trials are being done, none of them are positive. So there's over 150 clinical prospective randomized trials right now in sepsis, and the amount of things that we use today are currently 0. So either studies are negative, or every once in a while we have a positive trial like Zygris, and then we repeat it and it's negative. So here's just a quick list of things that if I had talked here in the last 5 to 7 years that I would have told you clearly benefit patients in sepsis. Tight glucose control of 80 to 110, which we don't do anymore. Zygris, which is now off the market. Mandatory central lines in septic shock, which we don't do anymore. Mandatory SCVO2 measurements in septic shock, which we don't do anymore. Transfusing to hemoglobin greater than 10 if you have a low SCVO2 in septic shock. We don't do anymore. Courtship stimulation test to guide steroids. Every one of these had a prospective randomized trial in the New England Journal or JAMA supporting it. And so if I had given this talk 2 years, 4 years, 6 years ago, I would have suggested that every one of these is absolute standard of care. And today I will tell you that none of these is standard of care. These are all things that we thought were right that were wrong. This slide is a list of new treatments for sepsis. Okay. So despite that blank slide, mortality from sepsis is steadily decreasing around the world. So how is that possible? And what actually is the state of the art in 2016? So again, when I did my disclosures, I'm part of the steering committee, formerly the executive committee of the Surviving Sepsis Campaign, and basically everything I'm going to talk about is going to be the Surviving Sepsis Campaign. So there's going to be no really cool, let me talk about the microbiome in the future in mice. This is going to be bread and butter things that we can all do at the bedside, and if we do them, there's no rocket science here. But if we do these, we will save lives. Nothing sexy, nothing huge. If we do these, we will save lives. More people die of sepsis than any disease in the country except for all of heart disease and all of cancer together. And I'm going to hopefully tell you that while we do some things remarkably well in heart attack, and we do things remarkably well in trauma, we do things not remarkably well in sepsis. So the Surviving Sepsis Campaign is an international campaign dominantly led by a partnership between SCCM and the European Society of Intensive Care Medicine, with the goal of decreasing sepsis mortality by 25% over 5 years. The next guidelines will be coming out at SCCM in January. What's been the success of the campaign? The success of the campaign is really here. Biggest study is 30,000 patients from over 218 hospitals, of which, while we call this an international database, 217 are from the United States. So this is a really United States database with one from Europe. And the compliance with the bundles increased from 10% to 31% by the end of year 2. So let me stop that for a second. So not thinking about our mandatory requirement for sepsis reporting right now, compliance went all the way up to 31%. So who here thinks that that's a great thing? Oh my God, we do things right almost 1 out of 3 times. It matters. It matters because the longer you're in a campaign, mortality goes down by 0.7% every quarter. That doesn't sound like much until you think about it as 3% every year, 6% over 2 years, et cetera. That makes a difference. But more importantly, look at the mortality for people who have low bundle compliance versus high bundle compliance. Low bundle compliance mortality is 38%. High bundle compliance mortality is 29%. An absolute risk reduction of 10%. What counts as high bundle compliance? I know people think that the new CMS measures about sepsis, some people think they're wonderful, some people think they're terrible. I think they're unbelievably wonderful, and it's not because SCCM helped sponsor the bundles, although of course we did. The reason I think this is wonderful is what counts as high compliance. High compliance, 2 standard deviation outlier, is doing every portion of the bundles correctly 35% of the time. So if you do everything wrong, if you don't do everything correct 65% of the time, you are 2 standard deviations off in being better than the rest of the country. So that's unbelievable. I was talking at dinner last night, if you think about a heart attack, so it's obviously much easier to treat the initial bundles for sepsis, which I'm about to talk about, than it is for a heart attack. If you work in a hospital that has a cath lab, and you say, what percentage of people with an ST elevation MI can you get to the cath lab within 1 hour, which is the government mandate? Your hospital will tell you between 98 and 100%, and everybody assumes that's okay. If I talk to these people in this room and I say, if you have somebody come in with a gunshot to your ED, how quickly can you get them to the operating room? And almost every one of you will tell me within an hour. And when I'm about to say, give fluids, antibiotics, and measure a blood test, if the best we can do is 35%, then we really should be held to a higher standard. So if you have a short attention span, you want to listen to 3 and only 3 slides, it's the bundles, which is the next 3 things. So, measure lactate. Simply put, lactate going up, bad. Lactate coming down, good. Obtain blood cultures prior to administering antibiotics. We get the blood cultures first. We get the blood cultures first because it will help guide our antibiotic therapy. If you give your antibiotics first, and then you get your blood cultures, you will decrease by a factor of 2 your chance of getting back a positive culture, and then you will overuse antibiotics. You want to administer broad-spectrum antibiotics. There's a million different broad-spectrum antibiotics that are appropriate. Use one of those million. And you want to administer 30 cc's per kilogram of crystalloid for hypotension or an elevated lactate. The 6-hour bundle was revised about a year ago, and that has to do with the fact that, I'm just checking over here I want to make sure that I end on time because I get so excited I could talk about this for like 2 hours. The 6-hour bundle, start pressures. Start pressures for hypotension that does not respond to fluid resuscitation to maintain a MAP of 65. And if you're persistently hypotensive, reassess volume status. I'll talk about how you do that in the next one. And tissue perfusion, remeasure lactate. How do we assess volume status? This got simpler, even though the slide is more complicated, because we used to say that everybody had to have a CVP, and we used to say that everybody had to have an SCVO2, and everybody needed a mandatory central line, until 3 prospective randomized trials came out in the New England Journal of Medicine showing that early goal-directed therapy doesn't change outcomes. So this wording is compromise wording of a lot of really smart people who don't like each other to say what's the best way of doing it. So either a repeat physical exam or 2 of the finding. CVP, SCVO2, ultrasound, dynamic assessment of fluid responsiveness. Then you say, but wait a second, I do something differently. I use a Vigileo, I use a flow track, I do something else. That's cool, because the bottom line is we do not know in the year 2016 what the best way of measuring volume status is. It's almost certainly not CVP, but we don't know what the best method is. So it's obvious, it's simple, and again, there's ample data that, for lack of a better word, I'm not sure I'm allowed to use this, but we suck at this. And by we, I mean high-level medical centers, the United States, and the world. Again, 2 standard deviation outliers, 35% hitting those bundles. Blood cultures, antibiotics, fluids. That's it, in 3 and 6 hours. And we can't get it right more than half the time. So, critical component of sepsis care is rapid antibiotics. For every hour that antibiotics are delayed, mortality raises 7.6%. I'm going to say that again. For every hour antibiotics are delayed, mortality raises by 7.6%. I want an honest show of hands. Unlike before when I said who thinks about pneumonia in the gut, this is something that every one of us sees. Who in this room, show of hands, can guarantee that every single time they have a patient in septic shock, they get antibiotics within 1 hour? On a show of hands. 1, 2. Which puts you, maybe 3, which puts you exactly at the international average. So I've had the honor and privilege in the last 2 years, because of stuff with SECM, of having 23 international trips, and I've given a variant of this talk in 23 different countries. And 1 or 2 or 3 people across the entire room is exactly about what I typically see whenever I give this talk. Think about it. If you have a trauma patient, I'm talking to a trauma audience. If I said to you, how often can you get somebody to the operating room with a gunshot? You're going to say, I could do it every time. You're not going to say, I can't do it. The operating room's not ready. The ER's not ready. I don't know. We have a delay in the elevator. You're going to say, I could do that every single time. If you could do that, if your hospital can get somebody to the cath lab, you can get antibiotics into your patient within an hour. I understand there's things in the flow. You have to get the antibiotics. Somebody has to take off the order. Somebody has to bring you the antibiotic if you don't have it in a cooler next to you. You have to be able to put it into your patient's arm. That's actually not that hard. It's a lot easier than going to the operating room to do a trauma laparotomy. And it's a lot easier than taking somebody to the cath lab to get cathed. If you walk away from one thing from me today, it's not that the microbiome will change the world, although I hope it does. It's that I will look in the mirror and I will figure out a way to get antibiotics into my patient in 1 hour every single time, and I will double check to make sure that happens, because I will decrease mortality in my patients every hour by 7.6%. And everybody in this room sees a lot of septic patients. Antimicrobial therapy. Again, start it in the first hour. The bundle says 3 hours. Why is the bundle 3 hours and I'm saying 1 hour when we're aware of the data? Because the bundles are for a worldwide thing. The Surviving Sepsis campaign is a worldwide thing, and we say if you're in a middle-income country, you might not have the resources to get an antibiotic into your patient. So if you perceive that you live in a middle-income country, then I'll say 3 hours is okay. If you do not perceive that you live in a middle-income country in the United States, I will say 3 hours is not okay, because the data says for every hour you delay, 7.6% change in mortality. When you start antibiotics, kill them all, right? Antibiotic stewardship is incredibly important. So what does that mean? I've been in a room with Tom Frieden, the director of the CDC, who says starting broadly is appropriate stewardship. You start broadly, you kill everything, and then once you know what it is, you rapidly tailor down. If you do not start appropriate antibiotics to start with, if you want to be, you're so concerned about stewardship, you say, I'll just start ANSEF. You will double the mortality on your patient. You start broadly. And after you start broadly, every single day, you reassess to see, can I come down? You want to decrease resistance, you want to decrease toxicity, and you want to decrease cost. Start broadly, tailor down. When you're using it empirically, combination therapy should not be used for more than 3 to 5 days. Monotherapy as soon as possible. In general, antibiotics for 7 to 10 days, although that's a whole can of worms. Is there anything new that people in this room would care about? The STOP-IT trial. The STOP-IT trial published in the New England Journal of Medicine from a bunch of surgeons, basically all my peeps at the Surgical Infection Society. 518 patients with complicated intra-abdominal infection with adequate source control. They're only enrolled if you have complicated infection with either fever, leukocytosis, or GI dysfunction, and there's been an intervention to obtain source control. Patients are randomized to either receive 2 days until after resolution of fever, white cell ileus, to up to 10 days, versus a fixed 4-day course. So I know I'm speaking to a lot of surgeons in this room, and I know that there are a lot of surgeons in the room that if you're being honest, you like antibiotics. You might say you don't, you might say, oh no, I stop them early, and some of you are lying. And I know that. Because surgeons like antibiotics, and they like antibiotics in every city in the world. And so everybody says, what's the downside to antibiotics versus what's the downside to keeping antibiotics going? And so that's why the people did the STOP-IT trial. So what was the endpoint? The endpoint was a composite of surgical site infection, recurrent infection, and death. Patients who got 4 days, 21%. Patients who were in the control group, 22%. No difference. The mean antibiotic length, however, was 4 days versus 8 days. No advantage to longer antibiotic course. You say, okay, but you're an ICU guy, you've talked to me at all patients with complicated intra-abdominal infections. So we actually asked for surviving sepsis to Rob Sawyer, the first author, what happens in that septic patients. And he said, that's a great idea, I'll do that analysis, I'll give it to you, but I'll publish it too. So we just published it in the Journal of American College of Surgeons recently. Subset analysis on the STOP-IT trial of 112 septic patients. No difference in SSI, no difference in recurrent intra-abdominal infection, no difference in hospital days, no difference in days to infection, no difference to mortality. Bottom line, if you have somebody with a complicated intra-abdominal infection who gets source control, 4 days of antibiotics, prospective randomized trial shows absolutely no difference towards a longer course. I know you know this, and I know that there are some people in this room who have trouble not understanding this, but acting on this. There is no role for antibiotics in the management of non-infectious inflammatory disease. SIRS can look like sepsis. Trauma, by definition, looks like sepsis. Severe pancreatitis looks like sepsis. Trauma is not an indication for antibiotics. Pancreatitis is not an indication for pancreatitis. Not an indication for antibiotics. Burns is not an indication for antibiotics. Infection is an indication for antibiotics. Having an inflammatory response, antibiotics do not bring down your interleukin-6 level. They kill bacteria. So if you're inflammatory because you're infected, treat somebody with antibiotics. And if you're inflammatory because you're inflammatory, treat the underlying cause, but don't treat it with antibiotics. Steroids, this is the worst wording of any recommendation of all time ever. I feel badly because I was recently in a room and I said that, and I said it to the person unwittingly who actually wrote it. So I felt badly. So I'm going to take this ridiculously complicated double negative statement from Surviving Sepsis and put it into English. There's 2 major prospective randomized trials of steroids and sepsis using the identical, literally identical word-for-word entry criteria. The first one was published by Jalali Anand in JAMA, and it showed that if you give steroids for septic shock, mortality goes from 60% to 50% with no complications. An incredibly impressive decrease in mortality. Awesome. It was followed up by the Corticus trial in the New England Journal of Medicine that shows if you give steroids for septic shock, mortality goes from 25% to 25% with a bunch of complications. Not awesome, right? So how do you take 2 large-scale major prospective randomized trials and put it together? You end up with this bizarre statement which basically says, if you're not so sick, don't use steroids. If you're incredibly sick, do use steroids. So the bottom line is if you're like starting a second pressure, if you think your patient has a 1 in 2 chance of dying, steroids for septic shock are appropriate. If you think your patient's a little sick, don't. Taper patients from steroids when pressors are no longer required. Do not use pressors for sepsis, formerly severe sepsis, in the absence of shock. There was just a study that came out a couple of weeks ago in JAMA called the High Press Study, looking specifically at this. It doesn't prevent septic shock, and it doesn't prevent mortality. So if you have somebody who's septic and they're not in shock, the word steroid should not be part of your vocabulary. There are 2 more large-scale trials underway, so hopefully we'll get some clarity in the future. Should we still follow early goal-directed therapy? This was our standard of care for over a decade until 3 prospective randomized trials came out that showed there's no benefit whatsoever. There was another study that showed if you transfuse to 9 versus 7, we sort of heard a little bit about this morning, there's also no benefit in septic shock. So what should you do? The stuff on the left is early goal-directed therapy. The stuff on the right is my opinion in capital letters. The original early goal-directed therapy said keep a CVP of 8 to 12, and I wrote down sort of, because you have to pay attention to volume status. It doesn't have to be CVP. In fact, CVP is a terrible way of looking at volume status, but you have to do something to look at, I keep getting called literally while I'm on stage, and my phone, which is my timer. You have to do something to measure what your volume status is. Mean arterial pressure of 65, I wrote down probably. There's a prospective randomized trial looking at 65 a MAP versus 85 a MAP in septic shock. All comers, no difference in mortality. Patients with a higher MAP of 85 had a higher incidence of atrial tachyarrhythmias. So globally, shooting for a higher MAP is a bad thing. But in patients who had pre-existing significant hypertension, multiple drug hypertension, they had a lower incidence of needing to be on renal replacement therapy if you shot for a MAP of 85. So all comers, a MAP of 65 is reasonable. If you have somebody on 5-drug antihypertension therapy at home, that might be reasonable. Urine output of half cc per kilogram is reasonable unless you have pre-existing renal failure. SCVO2 of greater than 70, not in every patient. It does not change outcomes. Does that mean you should never check an SCVO2? It does not. I mean, you should check one when it's clinically appropriate. Transfusing people to a hemoglobin of 10 or hematocrit of 30? No, because there's loads and loads of data that we should not do that. Add dobutamine? Maybe. It makes physiologic sense. There's no data on it. Fluids. Okay, start with crystalloids. This is not trauma. Trauma, you heard all this stuff, run away from crystalloids. Sepsis is not trauma. We do not run away from crystalloids. We actually start with crystalloids. We start with crystalloids. We do not start with hydroxylethyl starches. The reason we don't, anybody here still using Hespan? Good, because the only reason we used it is because of a whole bunch of fraudulent studies that have all been taken off the market right now because of one person who's now in jail in Germany. So we start with crystalloids. There's increasing data that normal saline may not be the best thing. It's a non-balanced solution that causes an acidosis. When Surviving Sepsis 2017 comes out, it's still going to tell you it makes no difference whether you use normal saline or a balanced salt solution. I'm happy to talk about the data. It is conflicting. There's probably increasing data that normal saline might not be the best solution, but not strong enough that I can tell you unequivocally you shouldn't use it. When you fluid challenge somebody, what do? You give them 30 cc's per kilogram over 30, or a liter over 30 minutes. 30 minutes. If you tell somebody to bolus a patient, what will they typically do? They will put the pump on 999. That will give a liter over 1 hour, not over 30 minutes. If you want to bolus somebody over 30 minutes, you have to be explicit and talk to your friends at the bedside and say, I would like this on a pressure bag because I would like this in over 30 minutes, because you're really trying to rapidly expand the volume to see whether the patient is fluid responsive or not. How long should you give fluids? As long as you need to give fluids. Okay? If you give fluids and the heart rate comes down, the blood pressure goes up, they're responsive. That's a good thing. If you give fluids and the heart rate doesn't change and the blood pressure doesn't change, what are you doing? Making their lungs wet. You actually have to assess the patient at the bedside. I have like a minute and a half left, so I'll take all of albumin. Albumin, we have this complicated statement. We suggest the use of albumin with patients with severe sepsis and septic shock if somebody requires significant amounts of crystalloid. What is significant? It doesn't say, but you could probably think if you give enough crystalloid that somebody is becoming hypoxemic, you should give albumin. Why? There's a bunch of bad stuff on albumin. It costs 60 times more. This is based upon an old recommendation that included pediatric patients, the only way to get a significance, and it's including patients from the SAFE study, which was a negative trial in all ICUs, and it just took a subgroup population. So after that, after the last Surviving Sepsis, the Albios trial came out, albumin and septic shock in the ICU. 1,800 patients, 20% albumin given, and what happens? No change in survival. So if anybody's just read the abstract of the Albios trial, you'll say, there's no benefit. But then you actually read the paper, two subgroup analysis, severe sepsis, septic shock. Severe sepsis, no benefit, septic shock, definite benefit of survival. If you put all that together in a meta-analysis, what does this glass look like to you? Okay, meta-analysis number 1, 2014. Quote, human albumin for critically unwell patients, not robustly effective. Safe, does not support a recommendation. Meta-analysis number 2, same year. In this meta-analysis, a trend towards 90-day mortality was observed in severe sepsis with resuscitation with albumin. 90-day mortality of patients with septic shock decreased. So if you're somebody who's half full, use albumin. If you're somebody who's half empty, don't. The recommendation will be unchanged in 27 surviving sepsis. Final slide over here. I already talked about this. If you want to start a pressure, start Levophed. Don't start anything else, start Levophed. What do you need to do if you add a second-line agent? You could add vasopressin. There's 2 prospective randomized trials on vasopressin and septic shock. The VAST trial, which is old, the VANISH trial, which just came out a couple of weeks ago. Both of them show no change in mortality, no change in renal failure, but maybe in certain subgroups there's a benefit. That's a reasonable thing to add, but it's ungraded. Epinephrine is also reasonable to add. Neosynephrine and dopamine should not be used except in rare circumstances. For better or for worse, the state of sepsis care in 2016, the 3-hour bundle, and give your antibiotics within 1 hour. Give fluids, give antibiotics, and you will save lives. Here's your 6-hour bundle. Join us in Hawaii. Thank you, guys.